Welcome back to the Neurology 101 series on the ProPA podcast. I'm Dr. G, and we're continuing our movement disorders sub-series, part of our larger movement disorders and cranial nerve syndromes umbrella. Today's topic is one you're guaranteed to see on boards and in practice: Parkinson disease, a progressive neurodegenerative condition with hallmark motor and non-motor features. Let's dive in. Did you know Parkinson disease is the second most common neurodegenerative disorder after Alzheimer's? And while we often focus on the tremor, many patients experience non motor symptoms like constipation, depression, or anosmia years before a clinical diagnosis is made. Let's look a little deeper at the Kinder Patho. What is Parkinson disease? Well, it's a progressive loss of dopaminergic neurons in the substantia nigra, pars compacta of the basal ganglia. This results in decreased dopamine levels in the nigrostriatal pathway, impairing smooth, purposeful movement. A key pathologic finding are Lewy bodies, intracytoplasmic eosinophilic inclusions made of alpha-synuclein. All right, how do these patients clinically present? Well, we think of the big four, and the mnemonic for this is TRAP. I think of Star Wars. I think of the little pilot guy that says, "It's a trap." Yeah. So TRAP, think TRAP, Parkinsonian trap. Tremor, which is a resting or pill rolling tremor, often unilateral at onset. R stands for rigidity. We often think of it as cogwheel or lead pipe rigidity. A stands for akinesia or bradykinesia, which is slowness of movement and masked facies. And P, postural instability. We often see a shuffling gait, and in the later findings, we might see falls. Some of the non motor symptoms include depression or anxiety, constipation, REM sleep behavior disorder, anosmia, and cognitive decline in the later stages. Symptoms often start unilaterally and progress slowly. So, how do we diagnose Parkinson? Well, it's primarily clinical, based on history and physical exam. Unilateral resting tremor, bradykinesia, and rigidity strongly suggest the diagnosis. But there is no single diagnostic test. We want to see a response to levodopa therapy, and this can support our diagnosis. An MRI is typically normal, but may be done to exclude other causes if the presentation is atypical. All right, let's talk about treatment. So, symptomatic only, there is no cure for Parkinson, but meds improve the quality of life. First line for symptomatic patients includes levodopa, carbidopa, Sinemet, a dopamine precursor, and peripheral decarboxylase inhibitor. This is best for the motor symptoms, and long-term use can cause motor fluctuations and dyskinesias. Other medication options include dopamine agonists, especially in younger patients, MAO-B inhibitors, COMT inhibitors, amantadine, which shows mild benefit, which is helpful for dyskinesias, and anticholinergics, helpful for tremor in younger patients, but not well tolerated in the elderly. Advanced or refractory disease, we can consider giving the patient a deep brain stimulator, targeting the subthalamic nucleus or globus pallidus interna. All right, book med versus street med. Book med, we have a 65-year-old with a resting tremor, bradykinesia, and cogwheel rigidity, and they get better on Sinemet. Textbook Parkinson's. Street med, a retired music teacher says she's just slowing down with age, but you notice she doesn't swing one of her arms, has a masked facies, and takes tiny shuffling steps. This is not aging, it's Parkinson. Some quick clinical pearls. A tremor at rest, we should think Parkinson until proven otherwise. ET improves with movement while Parkinson worsens with movement. Levodopa is the most effective treatment, but delays in initiation are common. We also want to watch for dementia and hallucinations in late disease. And non-motor symptoms can precede motor signs by years. All right, time to practice our knowledge. A 70-year-old man presents with a resting tremor and bradykinesia. He has no postural instability or rigidity. What's the most likely diagnosis? Is it A, essential tremor, B, Parkinson disease, C, Huntington disease, or D, vascular Parkinsonianism? The answer is B, Parkinson disease. We have a resting tremor with bradykinesia. Even without the full TRAP criteria, this is strongly suggestive of Parkinson's. Which of the following is a side effect of long-term levodopa use? Is it A, constipation, B, bradykinesia, C, dyskinesia, or D, seizures? I'll give you a few seconds. If you said C, dyskinesias, you're right. Levodopa-induced dyskinesias are involuntary movements often seen after years of treatment. All right, so some final thoughts. Parkinson disease is more than just a tremor. It's a complex, progressive syndrome with both motor and non-motor features. Early recognition and treatment can drastically improve function and quality of life. Next in our movement disorders, we'll move into Huntington disease, a devastating genetic condition with chorea and cognitive decline. If this episode helped you better understand the shades of gray between tremor types, send it to a classmate or quiz yourself with the TRAP mnemonic. And remember, this is the Pro PA podcast, where future pros in medicine are made. Thanks for listening.